healthcare especially, I think the amount of innovation is happening is unbelievable. It's not only in gynae or in infertility. I mean, I'm in the gynae and the infertility side, but in cardiac care and in nephrology and in every place. The world got its first baby, Louise Brown, in she was born on I think July 25th, 1978. And that's when that kind of thing came up, I think, in my parents saying, why can't we do this? Why can't we also bring the same technology to our country? Most of the IVF and the IUI procedures were first done in animals and in cows.
Yeah.
And a lot of people thought my mom was mad, because she was spending so much of money on this with no returns, and there was no guidance. Now we have, whole world is doing IVF. And there was no guidance at all. Whatever it is, you can never take out that human touch. You have to be there for the patient. You have to, our patients, they come with so much of a baggage because society is not kind to women who do not have babies. Unfortunately, even in this day and age. In this day and age.
Especially in our country as well.
In our country, such a societal stigma.
Hello everyone. Welcome to the next episode of Evolve, talks about healthcare's digital evolution. I am Vikalp Sahni, your host, navigating this dynamic landscape of healthcare and technology. It's my privilege to introduce not just an extraordinary individual, but also the inspiring legacy she represents, Dr. Devika Gunasheela, a gynecologist and managing partner of Gunasheela Surgicals and Maternity Hospital, a pioneer in fertility and reproductive medicine. Under her stewardship, Gunasheela has become far more than a hospital. It's a place where hope meets achievement. Founded over 40 years ago by Dr. Sulochana Gunasheela and Dr. Gunasheela, this institution has grown from a small clinic into a premier fertility hospital, recognized nationally and internationally for its excellence. What sets Gunasheela apart is its unwavering commitment to combining cutting-edge science with deep empathy. It was the first in the region to achieve numerous milestones, including South India's first ART baby, India's first in vitro maturation baby, and the establishment of one of the country's first genetic testing and intervention labs in a hospital, to name a few. Dr. Devika Gunasheela continues this legacy, nurturing both medical excellence and the dream of parenthood for countless families. Join us in this episode as we explore the inspiring journey behind Gunasheela, the passion that drives it, and the groundbreaking technology advancements poised to revolutionize fertility medicine. Hello, Dr. Devika.
Hi, good morning,
Good
Vikalp.
morning. Thank you so much for giving us your time for Evolve. This is our podcast where we talk about health, we'll talk about technology. Thanks for giving your time. And to start off, would really like to know a little bit of your history, your story, the 44 years of legacy that Gunasheela has made. About your mother. She is a pioneer in this field of fertility, and how you ended up becoming a doctor yourself. So
Yeah.
something about this whole journey.
First of all, I must thank you and your whole team for having come here and, doing this podcast. Second thing is that we are actually, if I may make a correction, we are going to be 50 next year.
Oh, wow.
So it's 1975 that we actually started, and Gunasheela is going to be 50. And when we started, we were maybe one of the posh hospitals in South Bangalore. And I remember my mom telling me that she was talking. There was one very famous architect called Zakaria and Thomas. They were a firm, and they kind of were the architects for this hospital, and they wanted. My mother was telling me that she used to complain that they were wasting a lot of space. So they would say, "No, doctor, you have to have a lot of light in the hospital, and let us make it a little bit new, because all the other hospitals were dark and kind of dingy and everything as old time." Yeah. So she said, "Okay, fine," and she, both my parents, kind of decided that they would go with whatever Mr. Zakaria said, and they built this hospital, and it at that point of time, and I think must be half of South Bangalore delivered here.
Wow.
So many times nowadays I see patients who come and say, I was born here, and I've got my wife now, and I wanted to deliver here. So it's a kind of a legacy, it goes on, and I have people who have had some 30, 40 women in their house delivering families, and they all live in joint families, and so it's a huge journey now for the last 50 years. So it started off as a surgical and a maternity hospital, of course, involving gynae also. And both my parents were in England for a long time. They came back in 1965. And then my father joined Bowring Hospital. I do not know if you
Yes,
Bowring Hospital. And my mother joined Vani Vilas, and they were both working honorary.
Okay.
And my mother's passion was, I think, infertility at that point of time, or it must have been in her mind. And there's nothing much at that point of time, anywhere in our country. And there was a lot of research happening in the world. But in our country, it was more of, what could you do? Don't worry, pacify the patient, you'll get pregnant, and things like that. And so she was in Vani Vilas, and she would actually do these x-rays, which are called as hysterosalpingograms, where you actually push the dye into the uterus and you take an x-ray, radio opaque dye, and then you see whether the dye comes out from the tubes or not. So it's a way of clearing the tubes also, and to see whether the tubes are okay, because tubes, the fallopian tubes are very important structures where the sperm and the egg meet.
Right.
So if the fallopian tube is blocked, it's very, very difficult to get pregnant by yourself. You need some kind of treatment. So she started to do these HSGs, and then she would have to kind of beg the radiographer, please wait, every particular day of the week. She would, put in her money and then buy the dye, and, buy some few cannulae, and then which had to kind of be put into the uterus and push the dye and then get the x-ray and come and read it. and to her surprise, people were getting pregnant just after doing HSG, and it still happens even now.
Oh, wow.
There may be some small mucus plugs, some small blood clots, which you just flush out, and patients become pregnant. So that was the way it started then in something, I think, late 1960s and 1970s. After which I think the world got its first baby, Louise Brown, in she was born on, I think, July 25th, 1978. And that's when that kind of thing came up, I think, in my parents saying, why can't we do this? Why can't we also bring the same technology to our country? And I think at that time, a lot of research was happening at a very furious pace. And soon after that, I think there was this baby called Durga that was born. She's claimed to be the first Indian baby, second in the world through IVF. But unfortunately, the documentation wasn't very great at that point of time, so it was kind of pushed underneath the carpet. But it has resurfaced, and now she is the second IVF baby in the world. Yeah, and then we got our second baby, which was by Dr. Indra Hinduja in 1985 or 87 or something like that. And we got South India's first baby through ART.
Yeah, which is such a phenomenal accomplishment.
Actually, this day, that year.
Wow.
1988.
5th of December.
5th of December.
Wow. So it's a great day
Landmark.
to have this podcast. As well.
Yeah.
It's a landmark day for you.
Yeah, but the amount of work that went into building up a lab and trying to kind of get the scientists, and our scientists were from Bombay, from Indian Institute of Research and Reproduction. We had two scientists who came and who kind of looked after the lab, and we had a very senior veterinary doctor who came because most of the IVF and the IUI procedures were first done in animals and in cows.
Yeah.
So we got somebody from the veterinary college who was used to looking at sperm and things like that, and then he learnt, and it was all very like early days, and then there were hardly anybody who actually knew about it, and a lot of people thought my mom was mad. because she was spending so much of money on this with no returns, and there was no guidance. Now we have, whole world is doing IVF, and there was no guidance at all. And how do you kind of start a lab, and how do you actually get your medication also was difficult at that
I'm
time.
just imagining those days there would not have been internet.
Nothing.
There would not have been like mobile phones.
No, nothing.
and like getting a lot of exposure for these new technologies built elsewhere
Yeah.
in the globe.
Yeah.
It would be so hard, but still the perseverance of getting it done would be so high.
And it's a dream, it's pursuing that dream that I must get this technology here. If they can do it in the West, why can't we do it here?
Yeah.
And it was a lot of effort that went in. She would go and she would study in St. John's library, and every day. And I remember those days. Wednesday was a half day. So
How old were you that time?
I must have. You're wanting to know my age then?
Yeah.
I was little. I must have been about 10 or 11 or something, and it was she really kind of worked very hard, and she built the first lab, and then we got our first art baby. And then actually this room where we are sitting and doing the podcast is the room where we actually had the first lab.
Wow.
But then we were not getting good pregnancy rates at that point of time. And so it was hardly reaching some 8 or 9% at that point of time. That was in 1988. So then she actually went and explored the pharmaceutical model. So in the pharmaceutical companies where they actually manufacture drugs, they have these huge systems where they have air filters and air purifiers, and then you have to kind of change into different clothes, and you go to get into an air shower, and then you kind of get into the lab. And so from I think BPRL, that's where we got our model of putting in air filters, and I think we were the first in the country to have air filters in the lab. And actually it's an old system which we're still continuing right now, but our one whole area, which I will show you, one whole floor upstairs is dedicated to air filters. Of course the systems have become much more sophisticated at this point of time, and you have labs which have inbuilt air filters in the walls, and so
but it was a need at that point.
It was because we were finding that even in this kind of a room, which was very inside the hospital and not exposed to any, the windows were closed, and if not exposed to any outside atmosphere, we still had dust. Which is the difference from our country to the Western countries. I've heard, I do not know, I've never been to Switzerland, but I've heard that in Switzerland you can drive around, and if you do that to the car, you won't have any dust. So
nothing, not that you see it here in India. And I think these are some practical challenges or the local challenges that
we had to face.
solve.
And once we and I think the new lab came up in 2000. And once it was connected to a dust-free atmosphere, our pregnancy rates soared.
Wow.
Yeah. And I think, and a lot of, shall we say, like the drugs also came only in stages. So the first drug that came out was clomiphene citrate, that was there in the West, and it always comes a little later to our countries, the developing countries. Then we had gonadotrophins, which were drugs that were isolated from human menopausal urine. So menopausal ladies were kind of made to pee into this place, huge pools of urine, where they isolated gonadotrophins from the FSH and LH, which are the hormones that are required, which are endogenously produced in our body. And those help in stimulating the ovaries to produce eggs. So from that huge pool of menopausal urine, FSH and LH were extracted. These hormones were extracted, and then they underwent so many purification processes. So we had the plain HMG, then you had highly purified HMG, which had very, very low levels of proteins, because these proteins were found to produce reactions when you gave it to women. So that was in the 1970s. Then 1980s, I think, and early 1990s, we got recombinant technology. So drugs were produced through recombinant technology. So like that, we also, I think, she also learned how to grew with it and learned how to use these drugs. And that learning process is a long learning process. And
during that process, obviously, you as a student would also be inspired to become
Yeah, I was watching. I was watching all this, and I did my basic medical course from Bangalore Medical College sometime between 1987 to 1992, and then went off to England. But somehow, for me, in my own mind, there was no other I wouldn't say as an option. There was nothing else that came to struck my mind. I didn't want to become. I was horrible in maths. I think that's why I became a doctor. so so I there was only that in my mind, that I had to just become a doctor. It was a natural conclusion. There was nobody who pushed me. I do not know if my parents indirectly pushed me into that. I have no idea. But in my mind, it was only I was going to become a doctor.
Yeah. No, in my family, the brighter kid wanted to become a doctor. The next best would basically become an engineer.
Oh, no, I don't think so.
That's how it worked out for me and my brother as well. He's a doctor. My cousin.
Okay.
And because he was much more smarter and brighter.
You would answer so many things.
That's
You must be
just,
the brightest one in your family now.
That's just pure luck. But I think I mean, yeah, this journey is simply phenomenal, and I think what you would have seen in this journey of 50 years, obviously, you would have got a lot of first-hand experience, even as a child growing up in that family, on the whole healthcare and the evolution of healthcare,
Yeah.
and how things are changing, be it medicine, be it the way of diagnosing a patient or surgery. There's so much that has happened over in the last 50 years.
Yeah.
So any areas or micro trends that you see are shaping up healthcare in general, which you feel are super critical and can help in patient care, can help in...
See, it keeps on happening. It's not only now. It's going to happen now. It's going to happen in the future.
Yeah.
Like, for example, as you were just talking, I wanted to mention that Gunasheela was the first which introduced ultrasound in Karnataka.
Oh.
Ultrasound now is a test that everybody uses, and it's
Yeah,
like, it's just taken for granted.
Yeah.
So we got our first ultrasound machine, and we first started ultrasound here for obstetrics and to look at the baby's heart and to look at the baby. And then it was laparoscopy. You heard of laparoscopy, which is So laparoscopy, again, we did the first diagnostic laparoscopy here. I'm talking about in the gynecological side. And we used to do a lot of laparoscopic sterilization camps, where you used to take the laparoscope and then go around to a lot of corporation hospitals, and they used to have these camps, and for women who wanted it. So like that, there are trends that are happening in the medical field which have been happening all the while, and whether it's how much you want to kind of take it up and adapt to it, or adopt it into your own system. Again, we were the first ones to do hysteroscopy in Karnataka. Yeah. So we have a lot of firsts. I mean, Dr. Gunasheela has a lot of firsts to her name. And healthcare especially, I think the amount of innovation is happening is unbelievable. It's not only in gynae or in infertility. I mean, I'm in the gynae and the infertility side, but in cardiac care and in nephrology and in every place. And change is constant. It changes the bottom line. It is underlies everything. There is going to be change.
Yeah.
How you're going to move with it and how you're going to look at it is a different story.
Right.
So we came from ultrasound, laparoscopy, hysteroscopy, and then we were doing pretty well with IVF. Then what next? You can't just become stationary, right?
Yeah.
You have to do something.
Challenge the status quo.
Yeah. So then we did IVM. And we were the first ones in the country to get an IVM baby. That was in 2004.
Yeah.
And that was much before England got its first IVM baby.
That was, I think, the fifth IVM baby in the world.
That was with frozen IVM is a technology where you take out immature eggs from a woman and mature them inside the lab for 24 hours and then inject them with sperm.
Yeah.
And we did it with frozen eggs, IVM, that is immature eggs that were matured, and then we made embryos when we were frozen, and that was the fifth one in the world. But we were the first ones which had IVM baby in India.
Yeah.
And we still have the largest data set for IVM patients.
Wow.
And we were helped, like I was telling you, we have Dr. Son here, who is now come from Korea. I mean, he's basically a Korean who was in Canada, now in the UAE, and one of the world famous embryologists. So we keep bringing him over and over again to come and see is there anything else that we can do in our lab to, improve it. So
This is so phenomenal. What drives this, doctor? So the first ART baby in South India. There's so much that is happening. You said that, okay, no, we want to do this here. Then, as we were talking about IVM as well, the first in India, fifth in the world. Again, these are all cutting edge stuff.
yeah.
So, what is it that drives you, and what is it that drives Gunasheela, in general, your center, to take these bold as well as very important steps? Because I'm pretty sure these are not easy, right? Setting
No.
all these things up would be very difficult. So, what is?
See, I think it started off with my parents' passion to start a hospital, and then it started off with my mother's dream to bring this reproductive technology from the West to here. It was driven by that passion, and for me, what I can say is, for me, I now Gunasheela has become a tertiary referral center. So people who fail everywhere come back and say, I have to get a baby from here.
And these are the things that I've also heard, and when I was also speaking at my office, that if nothing works, then let's go to Gunasheela. That's how it is.
Yeah, that's how the patients also come. So I must call it, I thought I was rename Gunasheela as Last Hope Hospital. So the thing is, it's the passion to try and do the best for the patient. Patients will come. I mean, there are patients who come and who have a lot of faith in you, and this will blindly accept whatever you say, and we can't. What do you call it? Mislay or whatever. You can't. You can't
Misguide them.
or you can't not misguide them. You can't. Their trust is in you.
Yes.
So
you have to do your best to
solve their problem. And there are other people who will come and say, okay, I've done this in XYZ hospital. What are you going to do different?
Yeah.
So there are technologies which actually you can use. And of course, some of them are controversial. Some of them are still being debated all over the world. Like for example, we brought in what is called as, and we were the first ones again to have the embryoscope. At that point of time, in 2012 or 2013, we got India's again first or second embryoscope baby. And they were twins, and we brought the embryoscope because it is a special incubator, which is see, now what happens is that when you do an ICSI, you take the egg and then you inject the sperm inside it, and then you have to wait for it to fertilize, and then you have to keep on taking out these dishes in which they are kept from the incubator to the microscope and have a look and see, because that's the only way you're going to see how the progress of the embryo is. And it follows a timeline. So at so many hours it has to fertilize. After the sperm is being injected, after that it has to become so it becomes one cell, then it becomes two cells, and then it becomes four cells. For every cell divides, it becomes 8, 16, then it becomes like a ball of cells. So those stages, so everything you have to take it out and have a look. So when you take it out of the incubator, which is a very controlled atmosphere of humidity, temperature, pH, etc., you're exposing it to the atmospheric air when you're putting it into the microscope. So the embryoscope is an incubator which actually takes real-time photographs every 20 minutes or so. You can keep the old incubator that we had. We could keep 72 embryos in that. Okay, so of 6 different patients, and it would go. You would have a camera clicking the photos, and it was a very controlled atmosphere. And that was relayed. The photographs of the embryos were relayed onto a computer. So you didn't have to actually open the incubator, take these slides out, take these embryos out, and have a look at them. So the stress that it undergoes when you actually take it out and have a look at it, and then expose to light and atmospheric air and pressure, etc.
It just goes away.
It goes away.
Yeah.
So the embryoscope was an excellent system to actually try and find the best embryo.
Right.
So we
And that would have helped in improving the
pregnancy rates. And we found that in our own, and we are one of the hospitals that have a lot of data.
Okay.
And I insist on keeping the data, because otherwise I feel that if you need to publish, if you need to kind of prove something, you need to have your own data, and which a lot of people don't have. And so what I was trying to say is that this embryoscope we found when we did our own studies, etc., was very helpful in women who had who were a little bit of advanced age, more than 35, 38 years of age, and also in women who had recurrent, what are called as recurrent implantation failure. That means they have had multiple IVFs and then they have failed. So, so that was the subset of women. It was also very good for research purposes, because it not only looked at the shape of the embryo, and the cells have to be regular, there have to be that many cells, etc., etc., and also looked at the kinetics. Kinetics would be the timeline that the embryo followed,
Okay.
the division pattern.
Wow.
So it looked at the timelines as well as the morphology, so it is called morphokinetics
Wow.
of the embryo. So, and then
It's like you're making like a whole baby or a human right from that.
you must see. When I got some videos, and now I'll tell you about our embryoscope, what happened. So we used it, and then we made our own. Even the company who sold it said that make your own algorithms. So as we kind of looked, as we did more and more patients, we kind of we worked backwards. So we transferred these embryos, they got pregnant. So from pregnancy, which embryos, which egg, we worked backwards, and we looked at the timelines, and we made our own algorithms, and we became very good at it, actually.
Yeah, no.
Yeah.
And these are quite a deep work, which practically, and that's why, as we were discussing, everybody, when nothing else works, then let's go to Gunasheela has become.
Yeah.
So that's sheer passion for the right patient outcome.
To do the best for the patient.
The best experience and the best outcome to the patient is what taken to take these big leap of faiths on technology as well. That we have to bring this. Let's see what happens. Invest on it. That's also would be one important thing. But while this is all happening, and everyone today is talking about this big fundamental change, including us technologists, is the whole generative AI and AI, and how that is transforming all the industries. And it's practically used a lot in what we do in our craft, that is on creating softwares. And it is coming to all other industries as well in solving for multiple different things. So what is your take on AI? How do you see that is coming in and helping doctors or healthcare professionals, or what's your views in general?
I think AI is coming up in a big way in all fields. And in our field, in fertility, they're looking at trying to select the sperm, the best sperm to be injected into the egg during ICSI, which is intracytoplasmic sperm injection. You take the egg and you inject the sperm.
So like from a group of sperms, you try to basically get the best one out.
Yeah, and I'm going to be having, after this podcast, I think we'll have a meeting with some international person who is trying to kind of, demonstrate his software, this AI software, whatever it is. I'm very bad at technology.
Can't be good at everything, or maybe people can.
But so he's going to demonstrate and tell us, he's wanting us to use his software to see whether it makes a difference. They're also using AI to try and select the best embryo. Like, for example, I talked about this embryoscope. So we were using it till this COVID business, and then once COVID came, there was nobody to come and service it, etc., etc. It was already been, now in 2022, it had been 10 years from the time that we bought it. So they said, and these companies keep changing their models, and they kind of, push you to buying their new updated models. So the embryoscope now has AI, which will help you, which they claim helps you to, or which I'm sure is there, which helps you to pick up the best embryo. With their algorithms of morphokinetics.
On the embryoscope itself, so that it can then give you the selection that this one is working out the best.
So it'll tell you which ones are the bad ones, which ones you can freeze, which ones are the best ones. So you choose from the ones that are the best and put it into so that it is apparently using AI for that. It's using AI is now coming to try and see which egg produces the best embryo. So it's really kind of going into kind of, really basics. And also, I think they are trying to, there is something called as pre-implantation genetic testing. Okay, so where you actually have an embryo, and see what happens is that for a pregnancy to take place, about 75% of the responsibility falls on the embryo, and maybe about 70 to 75, 25 to 30% falls on the uterus. Okay, so now how an embryo which is morphologically, that means just to have a look, is fine, it's dividing nicely, the cells are beautiful, it's done all its, passed all its timelines correctly, etc., etc. That is obviously the best choice to put in. But what is happening inside, we do not know, which is genetically. It's like, seeing a beautiful woman, but she may be having diabetes, she may be having high blood pressure, which you will not actually see just by looking at her. You'll have to examine her, you'll have to test her. So like that, an excellent embryo can also be genetically abnormal.
Oh.
So when you put that embryo in, thinking that it's the best embryo and it's fantastic, you may not get pregnant. The patient may not get pregnant.
Because of the genetic inefficiencies.
Yeah. So that's where this thing called pre-implantation genetic testing comes in. So how do you make out a fetus or an embryo is abnormal? Fetus is abnormal, you do a test after the patient becomes pregnant, and you have a scan and you have some suspicious findings. Then you can go and take out the fluid that is inside the around the baby, or you can take out some what you call cordon villus, which you can take out at 12 weeks and examine that, and if the baby happens to be abnormal, then you have to terminate that pregnancy. Going one step before that is looking at the embryo.
Right.
Of course, these are a lot of controversies about it, and it's still a very highly debatable subject, but then a lot of people have adopted this technology. And in that pursuit of what else can I do for this patient, I opened a genetics lab, which is called as Tattva Gene, to look at the genetics of infertility. And so we started to do pgt-a. And we found, that's the time when we found that, really good embryos can also be abnormal. But it can't be used for everybody. It can only be used for a specific set of patients. Like suppose somebody is like advanced maternal age, or husband has a lot of sperm problems, or the sperm is not good. Or if somebody is having recurrent, like I said, implantation failure, multiple IVFs and not getting pregnant. So those are the few subsets of people where we would use it. We wouldn't use it for somebody who's, shall we say, 32 and, coming for an IVF and has been married for a long time. So we wouldn't use it for those kind of people. So
it'll be more on a more complex scenarios where and maybe first time it got failed, and then the second time you have to check.
Second or third time,
Second or third time,
is
where you go into that whole genetic. And do you think there also a lot of AI and all of these?
Yes. I think now they're trying to kind of see whether these embryos that are recognized by this AI technology, etc., is they're going to be genetically normal. So can you predict the genetic normality of an embryo with this AI technology?
Wow.
Yeah.
That's and yeah. So I was when I look at healthcare in general, AI, and this is pretty new to me. There's a lot of work that is happening on imaging, and AI is actually taking a lot of stride over there. There's a lot of work that is happening on a specific diagnosis as well. But the way now AI can help in figuring out or aiding on fertility related scenarios as well, which is just quite phenomenal.
It's also being used to, like for example, if a patient comes in, there are certain factors that you look at to decide what her starting dose of medication would be. That, that is also AI is trying to kind of, get into.
Which is getting into more personalized and even more, because every patient is different.
Correct, exactly.
And that's where if there is a assistant that AI can act as in giving more detailed information that can help doctor to even get deeper into that individual's personal.
So now infertility is now is into personalized individualization of treatment. So it's not one formula for everybody. You have to look at the patient and then see what his or her personal characteristics are, and then after that decide on what kind of treatment you're going to do and what is your dose, what is your starting dose, how do you going to kind of progress with their treatment. So individualization is I think what AI is going to help in.
No, and this is very important for AI also to help and to also actually get into even deeper aiding to the doctors is the digitization of the overall practice or digital data generation, because that's how AI eventually would be able to also help and aid.
Yeah.
So what are your views on EMR or doing digital? Because and this kind of a touchy topic as well when I speak to many doctors, because it's like uh, doctors would want to spend a lot of time with the patient, which is the right thing, but there is a merit of digitization, but that would also take away a lot of that will add up to a lot of administrative pain
Yeah.
for the doctors as well. So but without digital, the AI can, or any of these technologies can be only as much of a relevance.
Yeah, correct.
Because if you
Yeah.
don't give the whole patient history, obviously, how would you expect a AI to solve for or aid in that journey? So yeah, a little bit of a chicken and egg here that we also see when we talk to many doctors. Your views on
No, I think I'm a little bit old-fashioned when it comes to digital records. Of course, we have digitalized a lot of our records, but then I think maybe I mean maybe you should throw some light on this, because you're the real tech man and who's done a lot of work for the Indian government. But from whatever our legal advisor was saying, that you can, if you want, digitalize your records, etc., but the courts still want them in a written format. Now, I'm again from the old school where I actually sit down and write, when the patient is, or I have an assistant who's actually one of my doctors, my fellows, who's, writing down the records, whatever I'm saying, etc. And for me personally, when I go to somewhere else, I find it highly irritating if the doctor is looking at that, continuously typing something, and then not looking at you, and
Which is
you're telling them your problems, and then I don't know. I mean,
no, you are absolutely right, and I think
it doesn't give that personal
So I keep telling my team as well that we haven't been able to build the right kind of an experience so far for the doctors, and maybe now with AI, just as we are having conversation, maybe a doctor and patient
should
are
pick
having
up.
conversation, and then there is a mobile phone which is picking up this conversation, and your prescriptions or notes are getting generated.
I
where
think you
can
must do
just
something like that.
So we do have a product
Okay.
that we are deploying.
Which is going to look at listen to the doctor and translate it into notes or something?
Absolutely. We call it voice to prescription, where you have to just keep the phone with Eka app installed. Right now it is on iOS and iPad, where you just keep it and then press a record button. The conversation gets recorded, and then the prescription gets generated. So
Okay, but what about the notes?
Notes will also be there. So notes, prescription, everything, whatever is the conversation happening.
And that gets translated into written, or it's just on a sharing?
No, it's written, and not only written, it figures out that in the conversation, when you are talking about a medicine, when you're talking about a surgery, when you're talking about a procedure, or a simple diagnosis or a symptom, it grabs all of these things from the conversation and divides them into respective buckets. If you have told that, okay, you have to take this medicine, let's say there is a supplement that you have to take twice a day after meal, it converts it into a medicine with 101.
Oh, okay.
All of that is that AI does. So we are working on those kind of things.
Oh,
to
very
help,
smart.
help in digitizations.
Yeah.
But coming back to your other point, and I think there are a lot of these conversation about digital or written. I think I don't see there is any regulation around that.
Yeah, because you said that you have done it for the government of India,
So we work with Government of India on a very important mission called ABDM, which is Ayushman Bharat Digital Mission. And what that means is everyone should incorporate digital. And government hospitals, and now practically all the AIMS, are saying that all the prescriptions that we are generating will all be digital. It will be given to the patient on their Abha ID, which is like a unique health identifier that the government has created, so that everyone can exchange health records easily. So there is a big push there.
Is there I'm just asking out of a layperson's point of view with concerns to AI, is there a problem with confidentiality there.
So all of these data that is getting generated is either a patient's data where he has a consent and he can give on his consent to whoever wants that data. So it's a architecture is very consentful architecture, or it is with a healthcare provider. So the data never goes out of a healthcare provider's systems, and data never goes out of the patient system or patient's health record application unless and until any one of these they give access. So no one reads, even government cannot read. So that's the way this whole ecosystem is being built. It is very similar to how today we do UPI transactions, right?
Yeah.
If you look at it 10, 15 years ago, it would be like, okay, from mobile, in my father's language, somebody have access to my mobile, can take away all my money. So then I have to explain to him that, okay, no, it's the technology that is safeguarding all of this as well. And that's what government is planning. So yeah, I think digital is as good as written from a legal perspective.
Okay, so the courts accept it.
Yeah, but I agree with on that point that software has to evolve so that doctors spend more time with the patient rather than with the computers.
Yeah, exactly. So I think maybe one of the, I do not know. I mean, I'm right now what is happening is that whatever we're writing is now getting digitalized and kept in that server or something. I do not know.
Yeah, more like a scans and photographs.
So that
you have a history.
I have a history and I can access it at any time that I want. But then we're still not completely digitalized in our hospital.
Yeah. No. I mean, something that we wish as a company to digitize the records, and that's one of our ambitions. Like you have like a deep ambitions of solving for fertility.
Yeah.
But and such an enriching experience you had, what would be your advice to healthcare professionals, young doctors, entrepreneurs like us who are working on this healthcare industry?
Change is a constant. If you don't change, you're left behind. Okay? You have to kind of adopt and adapt to change. And there are companies every day that are coming out with new technologies, something to look at the sperm, something to look at the oocyte, something to kind of, so many technologies that are there. But is every technology okay? It may not be good for the whole system. It may be good for parts of your treatment. But again, technology is expensive.
Yeah, it is.
It is. So if you buy a particular, shall we say, technology to improve your treatment, it's only going to work on one aspect of it. So is it worthwhile? So jumping in and getting everything that is there in the market, and these companies will sell it to you. They want to sell it to you. They want to make their profits, and they're going to kind of increase the hype around it. But it's up to you to kind of see whether you actually want to get it in, because then it translates into extra cost for the patient. So finally, it comes down to what is good for the patient. So whether that technology, you actually need it or not. Can you do without it? Is it going to be such a huge impact on your own system, on your own practice, on your own treatment care that is going to, is it going to have such a huge impact that is going to, if you don't have it, are you going to lose out? Are the patients going to lose out? And no technology is actually like that. I mean, that's according to me, And there are certain technologies which you actually want to get into. Like, for example, I definitely want to get into genetics because I personally feel that everything is going the genetic way.
Yeah, that's one area that we are also quite excited, and we are now thinking of understanding genetic reports because that can give a lot of insights to the doctors. And
Yes. So when we did start genetics, we were doing pgt-a, then we did pgt-m. Like we were talking about thalassemia a little bit earlier. So you can have a husband and wife who are both thalassemia minor. So really not manifesting the disease to such a large extent, apart from just being a little anemic or having, if you cut your hand during cutting some vegetables or something, it bleeds for a longer time. But if by some chance a thalassemia minor marries another thalassemia minor, two patients with thalassemia minor, the baby can have thalassemia major.
Yes.
Okay, so that is a huge situation.
That was what our worry was at one point in time.
Yeah. So I'll tell you a story. There's a lady who had a gentleman who had sickle cell trait. Sickle cell anemia is another one of these blood problems
it
where
reduces
the
your hemoglobin
and then when the oxygen concentration in the blood comes down, the cells which are round, they're plate shaped, they become sickle shaped.
yeah.
Okay, so this guy had a sickle cell trait, and his uncle, he is a Maharashtrian. Uncle happened to open a lab somewhere in Nagpur or somewhere like that. So he got everybody in the family tested for this. So he found out, this chap found out that he had the sickle cell trait. Then he met his wife somewhere on some website, some matrimonial.com, something, whatever.
Yeah.
And then because she was also from that same region, and she was also Maharashtrian, and they got her also tested. They found that she also had a sickle cell trait.
Yeah.
I mean, yeah, how uncanny is that? Somebody you meet on a matrimonial website and something like that, and then so finally they both had sickle cell trait, and they came to us, and she had had a few, I do not know, she had had a few attempts at pregnancy. Then she came and said, I want this disease to just get out of my family. So I don't want my children to have it. So they underwent an IVF, and I remember very clearly, she had 13 embryos, out of which only one was sickle cell free.
Oh.
Some of them had the whole gamut, the whole disease. Some of the embryos were traits.
And all of this information, you got it from that genetic
testing. So then we put in that embryo, and by the grace of God, she got pregnant. She had a beautiful little girl baby, and that baby is free from the disease now. She's not ever going to propagate it to her generation unless she gets married to another sickle cell trait positive man.
Yeah. That's what it's in India. It's said that you should match your kundlis, rather you should match your
genes,
blood reports and genes and all of that.
Yeah.
Well, no, with that amazing story, I think.
What I'm trying to say is that the future is exciting.
Yeah.
It really is, because now they're talking about getting sperm from bone marrow stem cells, generating sperm, generating ovaries, and they have a gelatin they have a 3D printer where they make this ovary from some gelatin and something, and then they put in cells, ovarian cells there, and then these are supposed to be, they put it back into the body, and these are supposed to be inert, so they're supposed to produce eggs. So artificial ovaries. And now, I do not know, it's all over the net and everywhere else, is Ectolife. I do not know if you've people keep sending me messages, and I've seen it as well, where you have a pod where they keep the embryo, and then it's an artificial womb, and so apparently the babies can grow in it, and it sounds like something from science fiction, like one of these huge science fiction novels where babies are growing. There's a situation where you can, the exchanges, the gas exchanges, all the electrolyte exchanges happen. It mimics a womb completely. And then also you can apparently talk to the baby. You can sing to the baby through your phone.
Wow. Wow.
You must go and look at that video, and then they say it will come. It's highly futuristic, but it may come.
Yeah, the change is constant, as you said, and we have to adopt to adapt.
Yeah. But how much you're going to do, and how much is going to benefit that particular situation, and how much is it going to translate as a benefit to the patient, is something that is very individual, and we need to, as doctors, analyze that and kind of not jump into every innovation that comes into the market, because every innovation may not be the best thing for you.
You have to do your research.
Yeah.
You have to do your understanding of that, and how that reflects into the patient care.
Yeah, because patients are vulnerable. They come to you for help, and you can never take out that. Whatever it is, you can never take out that human touch. You have to be there for the patient. You have to, our patients, they come with so much of a baggage, because society is not kind to women who do not have babies. Unfortunately, even in this day and age, in this day and age,
especially in our country as well.
In our country, such a societal stigma, and to the extent that even patients who have had babies through IVF don't want to say that they've had IVF.
Yeah.
They just don't want to say that. So it's and they come with so much of pain. That is the first thing that you need to address.
Yeah, which is not medical but more mental. I mean, it's
Psychological.
mental, psychological,
Yeah.
rather than like physical.
And they have to come with a positive attitude. And I have seen positivity work like that.
Yeah.
It's finally I have two lovely daughters who are both swimmers, and it's finally mind over matter. If your mind says you can win, you can win.
Yeah.
You will win. It will push your body to win. So a lot of it is mind over matter. A lot of it is positivity. I tell my patients, if you come here crying, I'm not going to treat you. You have to come saying, I'm going to get a baby.
Yeah.
You have to, don't believe in me, believe in yourself.
Exactly.
So those kind of things, that has to come first, that human touch. Technology you will use to kind of improve the treatment, increase the pregnancy rates, do whatever you can. And you have to tell the patient that you have to make them understand why you're using particular technology. So,
But your positivity is supreme. Like without that, rest other things.
patient's positive. They have to say, yeah, I'm going to do it.
Yes.
Yeah, and it'll happen.
No, that's such a lovely thought, and with that nice thought of being positive about everything, is something that is a big takeaway for us as well. And thank you so much.
I must thank you for taking the time to come here today.
No, this is a lovely setup. I wish best of luck to you and Gunasheela Fertility
Thank you.
Center, and,
Thank you.
It'll solve for a lot of patients and will take even more soaring heights. Thank you so much.
Thank you, and all the best to you with all your ventures. You are also doing excellent work you did with Ayushman. No, what was that called?
So I built
Arogya Setu, and then this whole
PGT-a.
yeah, great. You're growing great guns as well. So all the best to you
Thank
and
you
your
so
whole
much.
team.
Thank you.
Thank you.